Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Tehran, and once again so grateful to be with you all from this educational platform, Hot Seat. And I have to say, as always, I'm so honored to be able to be the host of the biggest names and great lecturers from around the world. And today, again, I have a very dear friend and one of the true educators in the field of perio and implant. Daniele Cardaropoli is here with us from Italy. Hello, Daniele. Welcome to Hot Seat.
Hello, Omid.
So happy to have you, and so thankful that you accepted to present at the Hot Seat and accepted the invitation.
A big pleasure for me. Big thanks for all the friends from Iran that they are following live on Hot Seats. A big pleasure, Omid, and your kindness for the invitation.
Thank you so much, my friend. Today, the topic that we will talk about, and Daniele will have a great presentation for us, is about soft tissue management around the implants. And what is very important for all of us as implant surgeons is the aesthetic point of view that I'm pretty sure during this presentation you will get lots of great points and the key steps and factors that we should take into consideration in our treatment. And as a tradition, I will have Daniele's CV for all of you before we start the Hot Seat webinar, and then we straightly go to the presentation, and at the end for sure we will have a great discussion on the topic. Professor Daniele Cardaropoli earned his doctor in dentistry and certificate in periodontology from the University of Torino. He is an adjunct professor in periodontology at the University of Catania. He is also an active member of the Italian Society of Periodontology, European Federation of Periodontology, and the Italian Academy of Osseointegration and Academy of Osseointegration. He is a fellow in the International Team of Implantology, ITI, and an international member of the American Academy of Periodontology. He is also scientific director of PROID, Institute for Professional Education in Dentistry in Torino, Italy. He is the winner of the Goldman Award for the Italian Society of Periodontology and National Award for the Italian Society of Orthodontics. Dr. Cardaropoli is also a member of the editorial board for the International Journal of Periodontics and Implant Dentistry and Restorative Dentistry, a reviewer of the Journal of Clinical Periodontology and Journal of Periodontology, and the American Journal of Orthodontics and Dentofacial Orthopedics. He is also the editor of the textbook Soft Tissues and Pink Aesthetics in Implant Dentistry, which I truly recommend all of you to read this book. I had the pleasure to translate this book in Farsi. So for my Iranian and Farsi language people, it's going to be out very soon. And for international audience, this book by Quintessence was published in 2018, and it goes in depth in every aspect of the aesthetics and the key principles in implant dentistry that you need to know. So one of my top lists, and I hope when you read it, you enjoy it. I'm pretty sure you will. And also, Dr. Cardaropoli, I have to say that he maintains a private practice in Torino, Italy. Once again, with my absolute pleasure, Daniele, the platform is all yours, and we are ready for listening to your beautiful presentation.
Thank you, Omid, really on this screen, and to share some knowledge that we have today with my friends from Iran. So I will start immediately to share the screen. Okay, perfect. And so today I will describe with you some interesting topic related to implant therapy. And specifically, I will try to focus on the placement of dental implants in the aesthetic area. But I will not speak exactly about osseointegration. I will not speak exactly, or at least only about the relationship between the titanium surface and the bone. And I will not speak exactly about bone regeneration, bone augmentation procedure. I will try today to share with you um, some knowledge more on the side of the soft tissues. For many, many years in implant therapy, we have been focused about the possibility to place implant in an adequate zone of bone with an adequate volume of bone. And for sure, this is still true in 2020. But in the recent years, we have learned the very important role that is played by the soft tissues. And when we speak about soft tissues and the role played by soft tissues is not only because of the aesthetic outcomes, but also because of the function. So we know that the aesthetic is not only related to the soft tissues, and the maintenance of the outcomes in the long term is also related to the thickness of the soft tissues. The relationship between the implant surface and what we call the supracrestal soft tissues is really important. And just going back to 1991, we remember when Thor Berglund, Jan Linde, Carlo Marinello, they worked together and they published this paper. This paper is about the biologic width around the implants. We know that the biologic width around the natural teeth is genetically predetermined. And since an implant fixture is not something that has been created by nature, but is something that is placed into the jawbone by a dentist, by an implantologist, or maybe better by a periodontist, then the oral tissues will heal around the implant surface and after the connection with the abutment. And for this reason, also around the implants, we have a biologic width. But from the histological point of view, there are big differences because the fibers that are around the natural teeth can connect perpendicularly, so 90 degrees to the cementum surface. But when we speak about implant surface, the fibers usually remain parallel to the long axis of the implant itself. This biologic width is so important that we can switch from the point of view of the terminology, and we can speak about the soft tissue barrier. Together with my great friend Paolo Casentini, Omid, you already spoke about the textbook. We have published this textbook last year by Quintessence. And I know that I really hope that for all of you, my friends from Iran, also the Farsi edition will be available as soon as possible. In this textbook, we have focused a lot about the role played by soft tissues. And there are a couple of chapters that they will speak about the concept of soft tissue barrier. So we like to speak about soft tissue barrier and not only about the biologic width, because it has been proven that the thickness of the soft tissues surrounding the implant is important in keeping the bone. So it is important because this thickness is able to maintain the long-term stability of the marginal bone level. And so if we are able to provide adequate volume of soft tissue around our implants, probably we will be able also to maintain the bone stable. On the other side, if for any reason the thickness of the peri-implant mucosa is thin, something like less than 2 millimeters, we know that the biologic width will be established around that implant, also with some bone resorption and bone remodeling. Because it seems that from the statistical point of view, the biologic width around the implants is a little bit greater, larger than the biologic width around natural teeth. So we need more than 2 millimeters of soft tissue thickness in order to give long-term stability. So we can see that this relationship between soft tissues and hard tissue is so important, not only for the aesthetic outcome, but also for the function of the implants in the long term. And if I show you this case, okay, this is a nice lady, something like 42 years old. She came to the office with this problem. The implant was inserted something like 10 years before. She remembered that the former dentist performed a tooth extraction and implant placement in the same day, in the same surgical session. So we can imagine that this implant was an immediate placement. And what we can see here, 10 years after implant placement, is not a soft tissue barrier. The lack of the tissue, the poor quality of the tissue that we have here. There is no keratinized mucosa. And also the profile of the tissue. There is a big concavity. And so this tissue that is poor both in quality and quantity is not able to give stability and to protect the bone. So the concept of soft tissue barrier is to create a good volume of soft tissue that is able to protect the bone. This is the real meaning of this concept. And in this situation, it is clear that the soft tissue is not able to protect the bone. And for this reason, we have this situation with some superficial inflammation, okay? The implant, as I told you before, was inserted something like 10 years before. And for us, was not possible to understand what kind of implant it was, to understand the implant system that was used, also because the patient, unfortunately, was without what we call the implant passport. For us, was really impossible to go back in order to understand from the prosthetic point of view which kind of components were used. This point is really important because sometimes we can change the crown, other times we can change the prosthetic abutment. And in this situation, was not possible to change the prosthetic abutment. So our concept was as follows. We removed the old crown, okay? And the original abutment, the original prosthetic abutment was prepared with the feeder edge kind of preparation. Okay, so this is something that usually we use on natural teeth, but we can use this kind of feeder edge preparation also on implant abutment. And with this kind of preparation, we tried to make the abutment smaller in terms of diameter, and also to change as much as it was possible the angulation of the abutment, moving the abutment more on the palatal situation. Okay, the crown was removed, was the most apical portion of the crown was cut, and in order to give at least 2 millimeters of distance between the margin of the crown and the marginal mucosa. At that time, we were ready for the perioplastic surgery. And so I think I can use here, yes. I created a very large surgical bed because I know that I need a lot of supply. And so the periosteal bed should be wide, wider as possible. And so you can see here the surgical papillae were not with a triangle shape, but were very large, very, very large in order to increase the vascular bed and the supply. And also the base of the flap here in this apical portion was very wide. It is a trapezoidal flap. It was elevated completely in a split thickness way in order to create, as we can see on the picture here on the right, a wide and firm, stable periosteal bed. At this time, we are ready to go on the palate to harvest a connective epithelial connective tissue graft. And this epithelial connective tissue graft was desepithelialized on the table, on the surgical table, in order to have only a connective tissue graft. I wanted to achieve the best aesthetic outcome possible for this situation. And so we know that the gold standard is still what we call a coronally advanced flap with the CTG. So it is what we call a double layer technique because there are two layers. The primary flap that we just created that will be moved in the coronal direction and the connective tissue between the periosteum and the flap. So we have two layers, the primary flap and the connective tissue. This approach is still the gold standard in terms of long-term stability of the outcomes and percentage of root coverage. For sure, in this situation, is not conventional root coverage because we are treating an implant surface and not a natural tooth, but the concept is very similar. So with the CTG, we want to increase the thickness of the tissue. But since I want to have the best healing possible, I will cover the CTG with the primary flap. And so this is the clinical situation. You can see here on the left that the connective tissue was sutured, and so now there is a strong and direct contact between the connective tissue and the periosteum. It is really important if we want to have a good healing of the connective tissue, not to leave any coagulum between the connective tissue and the periosteum, because we need a direct revascularization after a few days without any interposition of coagulum. And then the flap. On the right, we can see the flap that was coronally advanced. So at the same time, the marginal mucosa, the peri-implant marginal mucosa was moved in coronal direction, and then the thickness of the tissue was increased with the use of the connective. Without leaving any epithelium exposed, the aesthetic outcome will be perfect. On the left, I used resorbable sutures, 6 resorbable sutures to suture the graft. And on the right, you can see that I used a non-resorbable suture 6O made of PTFE in order to move the flap in the coronal direction. And this is the healing. On the left, after 2 weeks, it is perfect because we didn't leave any epithelium exposed. So I don't really like that image like a stamp, okay? But I prefer always to work with the double layer approach, the double layer technique, because from the aesthetic point of view is much better. Then it is after 6 weeks on the right. In order to have stability of the soft tissue, before taking the definitive impression. In this kind of situation, I like to wait 6 months because we need to have the tissues stable. And so usually we wait 6 months. And after 6 months, you can see here, everything changed. There is a huge difference between the baseline, the time where we started. And so now the tissue is thick and in a more coronal location. So now it is a barrier. It is a thick barrier that will provide protection to the bone and of course also to the implant. This time is really easy because we take the definitive impression, and after that we deliver the definitive ceramic crown. So we can see here the relationship with the new ceramic crown and the surrounding soft tissues. We started with a concavity from the horizontal point of view, and now we have a big convexity. This tissue for sure will remain stable for many, many, many years. And I can show you here the difference between baseline on the left. The tissue was apically placed and with poor quality. And here we are at 1 year after the surgery. So really with this kind of surgery, it is periodontal plastic surgery, we can see moving from a concavity and giving a convexity. So this is soft tissue barrier. When we speak about soft tissue barrier, this is what we should have to keep in our minds. So this was a case where the implant was inserted many years before. And so we should try to recover the clinical situation and to improve the situation. But many times we are the leaders from the beginning. And so many times we have to take decisions, clinical decisions about the management of post-extraction sockets. So it means that from the beginning of the treatment plan, every single decision is in our hands. But I prefer to say that every single decision should be in our brain, in our mind. So what to do with a fresh extraction socket? When to place the implant? Always we have to go with immediate placement. Always we have to go with a delayed placement or with a stage placement. I think there is not a general rule that we should follow for every single case. But again, it's the diagnosis that will make the difference. And in order to understand what is the best clinical decision in the management of post-extraction sockets, we created this classification. This is we call a post-extraction sites clinical classification, in which we were able to understand that basically in our daily practice, we have 4 different types of post-extraction sites from the clinical point of view. In this classification, we were able to match the information that we can have from the radiological point of view and the information that we can have from the clinical point of view. So basically, we match the information regarding the hard tissue, the bone, and the soft tissue, the surrounding soft tissue, in 4 different classes. So we have class 1. Class 1 is an intact socket. It means that the buccal bone is intact. Not only the socket is intact from the point of view of the bone, but it is also intact regarding the level of the soft tissues. So we also have optimal soft tissue level. In other words, no gingival recession. So we have the buccal bone plate, no gingival recession, and also we have a good amount of bone, palatal and apical, to the natural root. It means that we have a proper quantity of bone needed for implant stability, for primary stability. So in this situation, class 1, the first indication is to go immediate. In this situation, we can achieve the best aesthetic outcomes going with immediate implant placement. Then we have class 2. Class 2 is a little bit different because the socket is intact. We still have the buccal bone plate preserved, and we still don't have gingival recession. So it seems very similar to class 1, but there is a big difference because of anatomical reasons or because of the presence of inflammatory lesions, periapical lesions, maybe the sinus floor, for example, apical to the root of the natural tooth, we don't have enough bone available for achieving primary stability. So there is no possibility to place the implant immediately. We cannot go with immediate placement. In this situation, there is a good indication for alveolar ridge preservation. We know that alveolar ridge preservation is a concept of grafting with biomaterial, the fresh extraction socket. And in this way, we will compensate for the marginal bone remodeling following spontaneous healing. After 4 to 6 months, we have a good volume of bone to place the implant. So we will go staged 4 to 6 months after alveolar ridge preservation. And we know that in average, these are numbers coming from the literature. We can maintain around 90–93% of the original volume of the socket. And the implants inserted in preserved bone will have the same outcomes in terms of marginal bone remodeling, marginal bone level, survival rates, success rates as implant inserted in pre-existing bone. Then we have class 3. Class 3 is different because we have a resorption of the buccal bone plate with also gingival recession. So we can say that the socket is not intact. The socket is not intact. In this situation, we have 2 or 3 several approaches available. One is ridge augmentation and staged implant placement. Another one is early implant placement with the Bernays concept by Danny Boozer, my good friend, early implant placement. So it means we remove the tooth, we do tooth extraction, we wait for 4 to 8 weeks. After that, implant placement with contour augmentation. This is a good concept in this kind of situation. And then we have class 4. In class 4, the post-extraction site is severely compromised because there is a large resorption of the buccal bone plate with large periapical lesions or inflammatory tissue. Maybe we can image huge periodontal infection and the need for extract of an anopless tooth. In this situation, we have to go staged. For sure, we never go with immediate placement. We can wait for spontaneous healing and delayed implant placement with the simultaneous guided bone regeneration, or maybe with a ridge augmentation procedure and a stage implant placement after 6 months. So we have different approaches according to the classification. And the classification is the base of the diagnosis. So look this case. This is an upper lateral incisor with a failure from the prosthetic and endodontic point of view. For sure, we need more information. We need not only the intraoral X-ray, but also the three-dimensional X-ray. So the CT scan clearly shows that we don't have the buccal bone plate. So here, try, okay, to use this tool, the buccal bone plate is gone. And not only, but we also have an apical displacement of the free gingival mucosal margin. So there is a recession. In this situation, there is a big contraindication for immediate implantation because we cannot treat the recession. And also the buccal bone is gone. And so we don't know where to place the implant platform. We cannot place the implant platform here because it would be too much apical and we will create a pocket with possible peri-implant complication in the future. So in this situation, we have to think and make the correct diagnosis. What kind of clinical situation is this one? This is class 3. And so with class 3, what we can do? We can do a rich augmentation. And so I trimmed resorbable collagen membrane, okay? And I placed the resorbable collagen membrane in contact with the soft tissues on the buccal side. So we are working flapless. You will see that when possible, my primary choice is always to go flapless, specifically in the aesthetic area. So we have a piece of collagen membrane in contact with the soft tissues on the buccal side. And then the socket is grafted with this biomaterial. This is a bovine bone mineral blended with 10% of collagen fibers. So we use biomaterial, possibly xenograft, in this kind of techniques because we know that they will maintain the long-term volume. On the other side, autogenous bone usually, unfortunately, will experience something like 50% of bone remodeling, on volume resorption. And then we will fold the collagen membrane on the top of the graft of the biomaterial, leaving the collagen membrane exposed. So I can introduce you this concept. It is called open healing. So we leave a collagen membrane spontaneously exposed without the aim of covering with the soft tissue. I don't want to move the soft tissue in the coronal direction. I don't want to create a coronal denser flap, but we have this kind of scenario for the healing of the wound of the soft tissues with open healing, and it works because it is a collagen membrane that will work like a scaffold, a three-dimensional scaffold. And on this scaffold, the soft tissue cells will colonize and run on the top of it. And what it is interesting, and always giving a look at the baseline situation. At the baseline situation, we have keratinized mucosa on the buccal side and keratinized mucosa on the palatal side, for sure. We have the palate. And so what kind of tissue will cover the membrane? Only keratinized mucosa. There is no other possibility. So in this situation, with a simple and predictable approach, we will have a lot of bone, we will cover the recession, and we will increase the amount of keratinized mucosa. Look, after 1 week, the yellow tissue that you see here is not pus, is not infection, is the layer of a fibrin on the top of the mucosa. So it is the, don't go with the pliers, don't try to remove this tissue, but just keep it, remove the sutures, and ask the patient to continue rinsing with chlorhexidine in order to avoid infections. And then we just have to wait. This is after 2 weeks, new tissue, new mucosa. And after 4 weeks, everything is perfect. I mean, the soft tissue will become more mature in the following weeks, but now they are closer without the infection. This approach works perfectly. Really, it works perfectly. We have a lot of keratinized mucosa now, and no more gingival recession. We can do whatever we want. And this is the healing after 3 months. Look the amount of keratinized mucosa. 4 months. And the X-ray shows a perfect healing. We can open the flap, and now we have a new buccal bone plate and a lot of bone. So it is very easy to place the implant. I always ask for a surgical stent in order to place the implant in a way that we call prosthetically driven. It is really important to place the implant prosthetically driven, because even if we have placed 10,000 implants in our life, for the patient is always just one and should be perfect. One shot, as we say. And so it is easy. We go prosthetically driven. We make a proper decision about the diameter and the length of the implant. We use small diameter, 3.3, 2.9, and this is the X-ray, and we can see the tissues that will surround the implant abutment junction, giving long-term stability. So now what we have, the biologic width, we can call the soft tissue barrier, the definitive zirconia abutment, and the definitive full ceramic crown. After 1 year, it is stable. And for sure, the marginal bone level are stable. And I can show you the comparison between baseline and 1 year after the end of the treatment, the delivery of the ceramic crown. Look, the tissue. The peri-implant mucosa was coronally advanced. Without a coronally advanced flap, I didn't raise any kind of flap. It was a flapless approach. But just thinking with the biology, we know that we can move the tissue, we can guide the tissue, because we lead the tissues, the soft tissues, in this situation. And this is another case, again, in the aesthetic area. And I show you the most important case for aesthetics in implant dentistry, upper central incisor. Unfortunately, there is a huge cavity. I can show you on the palatal side, close to the bone level. No way with surgical approach with apically repositioned flap and osteoplasty, or maybe some osteotomy. So unfortunately, I think that in this kind of situation, the tooth should be extracted. And for this, to make a proper treatment plan, we need a CT scan. The CT scan shows that the buccal bone plate is really thin. I hope you can see. Maybe it is 0.1, 0.2 millimeters. It is really thin, but it is there. It means that the socket is intact. And so we can imagine to have this situation like class 1, because the socket is intact, the buccal bone plate is intact. Even if it's thin, I will show you that there is not much difference, and there is no gingival recession. We have this triangle of bone here, and so we will use that triangle bone in order to obtain primary stability, good primary stability. The implant platform, also in the horizontal dimension, should be placed far away from the buccal bone plate, at least 2 millimeters, because we want to create a gap, a bone to implant gap. And the bone to implant gap will be grafted with a biomaterial. And so we will use the concept of alveolar ridge preservation together with implant placement at the same time of implant placement. This is really, really, really important. If we stay too much close with the implant to the buccal bone plate, then the buccal bone plate, because it is made of bundle bone, will be resorbed and the buccal surface will collapse. And we will have mucosal recession on the implant. But in this situation, moving the implant on the palatal side, we will have this gap here. And will be grafted with the biomaterial. This will give stability of the bone. I will show you. I think we can see together a video, a short video. I always like a flapless approach. We try to keep the soft tissue stable. We know that if we raise a flap, we will activate the osteoclast. And look, the implant site preparation started on the palatal wall of the socket. We never have to place the implant exactly into the socket where the bundle bone is. But the implant site preparation is different with the natural tooth axis. And we can see here, we have a big flap, a big gap, a big bone to implant gap. The implant is inserted. At least 35 Newton per centimeters, and we have the gap. And now we fill the gap. We grafted the gap with bovine bone mineral blended with 10% of collagen fibers. We use this bone plugger, and this is the outcome. And then we will prepare immediate restoration chair side. We place some enamel matrix derivative to enhance soft tissue healing, and we screw the crown. I think it's time we can see all these steps again together. So after anesthesia, we should understand where is the level of the buccal bone plate. If the buccal bone plate is gone, it's better not to place the implant immediately. And then we work at the soft tissue level. We use this kind of syndesmotomies in order to detach the supracrestal fibers, and we have to be really conservative to the soft tissue. We should keep the original architecture, the original anatomy, the original profile of the soft tissue. The root will be extracted. Again, with the periodontal probe, we check the level of the soft tissue and the level of the bone. This is really important because the implant platform will be placed 1 millimeter, around 1 millimeter apical to the buccal marginal bone level. And what I'm doing with the blade here, I'm removing the epithelium from the sulcus in order to expose the connective tissue, to improve the healing of the soft tissues. Again, I love to use a surgical stent because the implant will be inserted surgically driven and prosthetically driven. I really think that this is mandatory. And we can see how we have to change, how much we have to change the axis of the implant. The implant preparation is on the palatal bundle wall. The bundle bone is here on the palatal side. The natural apex is here. Don't make this kind of mistake. And then we enlarge the implant site preparation, and then we are ready. We can see the implant is around 1 millimeter apical to the bone. Now the implant is inserted. It is in what we call the comfort zone. It is perfect and is far away from the buccal bone plate. The bone to implant gap is grafted with a slow resorption biomaterial. And then I always ask, when we have good primary stability, for immediate restoration. There are two reasons. And one reason is because of the patient is always happy to go back home again with a crown that is fixed, not removable. And so from the psychological point of view is really happy. And the other reason why I always ask for an immediate restoration is because of the soft tissues. Is because I want to maintain the support of the soft tissue. If you don't give the restoration, if you not deliver the restoration at the end of the surgery, the soft tissue will collapse and we will lose the natural architecture, the natural profile. I don't care about osseointegration. We don't need to place the crown to achieve osseointegration. The implant will also integrate. Anyway, it's not the point. The point is about the soft tissue support. And so the pros will give the correct profile to the crown. And another point really important, always go with screw retain, because it is an open wound. I don't want to have some cement going inside the sulcus and maybe creating some infection. So the best option is always to go with screw retained restoration. And we are at the end of the surgery. Beautiful tissue. These tissues will become more mature and stable. And since we worked in a flapless situation, after 3 months, the tissues are stable and we can switch from the provisional to the definitive crown after 3 months. When we work in a flapped approach, no, we have to wait more. When we work flapless, 3 months are enough. And I can show you the thickness of the soft tissue. So we have created again the soft tissue barrier. And this thickness will give stability. And in this situation, we worked with a digital scan because we just have to do like a copy and paste. So we don't change anything. The information given by the provisional restoration will be transferred exactly as they are to the definitive restoration. Color, shape, everything will be transferred and we work digitally. I really love this kind of job like now. And this is the definitive restoration, and everything is stable, everything is perfect. I think everything is much better than baseline. And this is the comparison between baseline situation and 2 years follow-up. This kind of approach is part of a study, a randomized controlled clinical trial that we published last year in the International Journal Periodontics and Restorative Dentistry. And in this study, we were able to make two kinds of evaluation. First, radiological evaluation. Second, soft tissues evaluation. From the radiological point of view, we measured the buccal bone plate thickness at baseline before tooth extraction and the horizontal width of the ridge after 1 year from tooth extraction, immediate restoration with immediate implant placement. And also we did something really interesting. We created two groups. one group with a thin buccal bone plate and another group with a thick buccal bone plate. And we were able to show, performing a linear regression analysis, that there is no relationship between the final outcomes and the thickness of the buccal bone plate at baseline. It means that with this approach, we can have the same outcomes also when the buccal bone plate is thin, like in this situation. So the approach is placing the implant platform palatally, creating a gap and filling the gap with the biomaterial. And then with the same patients, we also evaluated the soft tissue, so the aesthetic outcomes, in terms of mesial papilla level, distal papilla level, and mucosal, midfacial mucosal level, and the pink aesthetic score. And we had two groups again, thin gingival biotype and thick gingival biotype. Today, I will use the term gingival phenotype, but it's the same. So, and the outcomes are similar without the differences from the statistical point of view. It means that with this approach, immediate restoration delivery, we can keep the original anatomy of the soft tissue, the original architecture, even if the phenotype is thin at baseline. And this is the way we concluded. So, Omid, I think that what we can say, speaking about soft tissue aesthetics and long-term outcomes in implant therapy, is that usually we should be able to provide treatment plans that will give predictability. I always like to use this sentence: we are what we repeatedly do, therefore excellence is not an action but a habit. It means that every day in our daily practice, we should be able to provide treatment in our patients with long-term stability. And the soft tissues are so important, not only to give aesthetic outcomes, but also to help to maintain the volume and the stability of the bone tissue as well. Thank you.
Thank you so much, Danielle. As I said at the beginning, you are truly a fantastic educator, and the way that you describe the cases, you go step by step in depth. I think it's a great chance for everyone around the world as dentists to enjoy this presentation and learn from one of the best in the field. And I have to say thank you again, truly, from the bottom of my heart, that you accepted this invitation and you delivered the best for all of us. So Daniel, some questions I have regarding the cases as a discussion, because everything was beautifully and clearly described, so no doubt about the sequence. But for example, the first case, the complication that you showed, that we had recession on previous implant, that for example another practitioner was placed and we have you did a soft tissue grafting. What will happen to the retention of the crown when we do that soft tissue augmentation? So the length of the abutment will be very short. So how we can guarantee to have enough retention of the new crown?
Well, I don't think we can be guaranteed in any case, in a case like this one. So if we need that to be guaranteed, I think we should remove the implant. But not always this is possible for a lot of reasons that you can imagine. Unfortunately, for that specific case, we were not able to understand the implant system that was used, and so we were not able to change the abutment. When possible, this is my first choice, to change the abutment. It's much better to change the abutment, to ask the lab to work on the new abutment with a good angulation, better than work on the chair and try to work on the abutment. So I agree with you that we can have some concern about that specific case about cementation, but it is still stable. So
Yeah.
for that situation, we are lucky.
And do you use permanent cements in those cases or temporary cements?
Usually, I never do the prosthetic by myself.
Uh-huh.
I have my wonderful doctors working with me in my team, Dr. Alessandro, Dr. Andrea, Dr. Lorenzo. So I have a team of pros working with me, but I know that usually on implant rehabilitation, they work with cement that should be temporary for natural dentition.
Exactly, exactly. And regarding the
Yeah.
cases that you do the socket grafting and you showed the way that you place the membrane under the flap and pack it with the xenograft and low turnover rate.
Yeah.
Do you use like a cross-link collagen or you go with normal collagen membranes? Should it be rigid or there is no importance?
It is a native. No, 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 no. It is not rigid. It is soft, and it is a native collagen membrane. I never use cross-link collagen membrane. I want to use native collagen membrane because I want to have an early revascularization. If I have to use something that uh, will long for more time, I will go directly with a non-resorbable membrane.
Uh-huh. Great, great.
But my concept is with resorbable membrane
Resorbable membrane,
is to
not
use
cross.
a native collagen, yes,
Yeah,
not cross-link.
not cross-link. And one of the other cases that you presented, the central incisor that had a caries in the palatal and the apex of the root was toward to the buccal. Actually, you very gently, beautifully remove that root without harming the buccal bone. So it needs a lot of skill. I want to know what is your thought on socket shield in such root positionings, in such cases, partial extraction therapy and socket shield in such cases that the root is.
I know. I have a lot of good friends first and wonderful clinicians like Maurice Salama, Awi Gluckman, so all members of the big XP family that I know they do a lot of this partial extraction therapy or socket shield. I don't know so much experience about these protocols. So what I can tell you that I continue to use my protocol, what I learned many years ago, and but I am aware that there are other possibilities. Probably also the PET is not technique that is so easy. We need a lot of skillness also to keep that piece of root on the buccal side. So I'm not sure that in that kind of situation with that thin tissue and thin buccal bone plate with the PET would be much easier.
Yeah. And Daniel, one final question regarding, because you demonstrated the classification of the extraction sockets, and especially in the article that you presented at the end, that you showed that we can gain predictable outcome whether it's a thin biotype or it's a thick biotype. So I want to know that do you consider putting the connective tissue graft in immediate implants especially in the cases of thin biotype, or it works exactly the way that you demonstrated?
No. We have this data for a randomized controlled clinical trial. And according to the data that we found, we don't need to place a CTG. But it is really important to understand that we have to go straight forward with the protocol. So we have to go flapless, not to raise the flap, because if you raise the flap, you will lose that thin buccal bone plate immediately. So you have to go flapless. You don't have to break the buccal bone during the extraction. And so everything should be done really carefully. We need a lot of skillness. And so if everything is done in this situation, in this situation, we don't need the CTG, at least according to the outcomes that we found.
Great, great. Thank you so much.
We have time. If we need the CTG in the future of that case, we always we have the time to do.
But you don't do it at the same time of the surgery. You prefer to evaluate and do it next stage.
No. If you are able to keep the original soft tissue architecture, yes. I prefer not to do the CTG.
Great. Great. With that said, Daniel, I truly want to thank you again for your time, for your kindness, for accepting the invitation and delivering the best for all of us. I know the topic is very interesting and we can talk about it for hours, but I know the time is limited and want to appreciate it again for everything. And also, again, want to tell the audience that if you haven't read this beautiful book by Danielle, don't miss the chance. It's beautifully demonstrated in every chapter, stage by stage, step by step, complicated cases, simple cases. And for all my Iranian friends, the Farsi version of this book will be out very soon. Danielle, with that said, thank you so much again, my friend, and stay safe and hope to see you very soon.
A pleasure. Thank you, Omid. Bye-bye.
Bye-bye.
Ciao.
Stay safe. Ciao.